Hi, I'm Dr. Alexandra Drakaki, an assistant professor of medicine and urology, the medical director of the GU Oncology program at UCLA and the Institute of Urologic Oncology. The question is why cisplatin-based chemotherapy like MVAC is the standard of care in the neoadjuvant setting, and what are the factors that determine if a patient is cisplatin eligible or ineligible. I'll start saying that cisplatin-based chemotherapy was first used for the treatment of bladder cancer in 1970, and since then remains the standard of care for the treatment of this disease. Clearly, the fact that we give cisplatin for 40 years now is a sign that this drug is very effective. Having said that, this treatment cannot be offered to every patient given the associated side effects. Therefore, every time we have a patient in front of us, and before deciding how we are going to treat them, the first question that comes to our mind is if the patient is cisplatin eligible or ineligible. I'm going to expand on this in a little bit as there are certain criteria we're using and of course modified to some extent depending on which setting we're offering therapy, as we are more or less aggressive when we try to treat a patient in the metastatic setting compared to offering chemotherapy with curative intent when treating someone in the neoadjuvant setting. We actually just published some data through SEER data analysis, and we found that the utilization of neoadjuvant chemotherapy was pretty low, but has increased over the last few years. And I think what led to this change in practice comes from the pivotal study that was published in New England Journal of Medicine back in 2003. In that study, patients were randomized to undergo cystectomy compared to neoadjuvant chemotherapy with MVAC followed by cystectomy. So that study that ran actually 20 years ago showed that subjects who receive chemotherapy in the neoadjuvant setting do have some survival benefit. Since then, there are many studies confirming that cisplatin-based chemotherapy is the standard of care and so should be offered in the cisplatin-eligible patients. So what cisplatin eligibility means? The consensus came after work from Dr. Matt Galsky from Mount Sinai, who presented at GU ASCO in 2011 the following criteria: creatinine clearance of 60 ml per minute, performance status ECOG 2, grade 2 hearing loss, which means people need hearing aids, and grade 2 neuropathy. Other important criteria is heart failure, as patients receiving cisplatin need hydration before or after chemotherapy. And so patients with those criteria are not allowed or able or should be getting cisplatin. More recently, there were two neoadjuvant trials run by Dr. Plimak and Dr. Cherry, in which dose-dense MVAC or accelerated MVAC was offered in the neoadjuvant setting and again proven to be safe and effective. Those two trials were published in JCO in 2014. But it's important to mention that not every patient is fit to receive MVAC. Regardless of the cis eligibility or not, MVAC tends to be a difficult regimen to get. People can have cardiotoxicity or losing their hair. If they're a little bit old and frail and have comorbidities, may not receive MVAC. So the alternative is still cisplatin in combination with gemcitabine. What I really would like to point out is that when we try to make the decision between cisplatin or another regimen, cisplatin is more effective than carboplatin. And so we should always try to optimize all the factors and try to offer cisplatin when possible. So for example, when patients have borderline kidney function, we should always consider splitting the dose of cisplatin instead of offering carboplatin. And a great example is the ongoing neoadjuvant Niagara trial, in which patients with creatinine clearance from 40 to 60 are offered split dose cisplatin, and specifically they receive cisplatin 35 milligram per milliliter square on day 1 and 8 of a 21-day cycle, while those with creatinine clearance above 60 receive cisplatin 70 milligram per milliliter square on the day 1 of the 21-day cycle. So it's important to use that as an example in our day-to-day practice when patients have borderline kidney function. Also, what is important to mention now is that Even if this is the standard practice, that may change as new trials are being designed to compare non-platinum regimens to cisplatin and gemcitabine in the neoadjuvant setting. So I will not be surprised if in a few years from now, and with the new advances in this field, we'll be approaching our patients differently, and same treatments will be offered in both cisplatin eligible and ineligible patients.